Volumes and capacity. A capacity is a sum of more than or equal to two physiological volumes. There are four volumes and four capacities. Tidal volume. It is the air that moves into the lung which each quiet inspiration 6 to 8 ml per kg, typically approximately 500 ml. Inspiratory reserve volume is the air that can be breathed in after a normal inspiration. Expiratory reserve volume, it is the air that can be breathed out after normal expiration. Residual volume is the air in lungs after maximal expiration. Residual volume and lung capacity, that includes residual volume, cannot be measured by spirometry. Inspiratory capacity is inspiratory reserve volume along with tidal volume. That is the air that can be breathed in after normal exhalation. Functional residual capacity is residual volume and expiratory reserve volume. That is the volume of the gas in lungs after normal expiration. The outward pulling force of chest wall is balanced with the inward collapsing force of lungs. Vital capacity is inspiratory reserve volume, tidal volume and expiratory reserve volume. It is the maximum volume of gas that can be expired after maximum inspiration. Total lung capacity is inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume, or also equal to vital capacity plus the residual volume. That is the volume of gas present in lungs after a maximal inspiration. Work of breathing, it refers to the energy expended or oxygen consumed by the respiratory muscles to produce the ventilation needed to meet the body's metabolic demand. It comprises of the work needed to overcome both elastic recoil and airway resistance. That is, work is equal to force into distance, also equal to pressure into volume. So it is minimized by optimizing the respiratory rate and increasing the tidal volume. It is increased in restrictive diseases. Increased work to overcome elastic recoil achieved with increased respiratory rate and decreased tidal volume. And obstructive diseases, the increased work to overcome airway resistance, which is achieved with lower respiratory rate and an increased tidal volume. Determination of physiological dead space, that is VD. VD is equal to VT, tidal volume, into PaCO2 minus PeCO2 divided by PaCO2, where VD is the physiological dead space. That is also same as anatomic dead space of conducting airways plus alveolar dead space. Apex of the healthy lung is largest contributor of the alveolar dead space. VD is the volume of inspired air that does not take part in gas exchange. PaCO2 is the arterial PCO2. PeCO2 is the expired air PCO2. Physiological dead space is approximately equivalent to the anatomic dead space in normal lungs. May be greater than anatomic dead space in lung diseases with ventilation perfusion mismatch. Ventilation. Minute ventilation is abbreviated as VE. Total volume of gas entering the lungs per minute. VE is equal to VT into RR. And alveolar ventilation abbreviated as VA. V capital A. That is the volume of gas that reaches alveoli each minute. So VA is equal to VT minus VD into RR. So the normal values are RR respiratory rate is approximately 12 to 20 breaths per minute. VT tidal volume is 500 ml per breath. VD, the physiological dead space, is 150 ml per breath. Lung and chest wall properties. Because of historical reasons and small pressures, pulmonary pressures are always presented in centimeters of water. Elastic recoil, tendency of the lungs to collapse inward and chest wall to spring outward. At functional residual capacity, airway and alveolar pressures equal atmospheric pressure, PB called 0, and intrapleural pressure is negative, which prevents atelectasis. The inward pull of the lung is balanced by the outward pull of the chest wall. Systemic pressure is atmospheric. Pulmonary vascular resistance is at a minimum. Compliance. What is compliance? Is change in lung volume for a change in pressure. Delta V divided by delta P. Inversely proportional to wall stiffness and increased by surfactant. Increased compliance means lung is easier to fill. Example, emphysema or older adults. Decreased compliance means lung is more difficult to fill. Examples, pulmonary fibrosis, pneumonia, ARDS, and pulmonary edema. Hysteresis, that is lung inflation, follows a different pressure volume curve than lung deflation due to need to overcome surface tension forces in inflation. Coming to pulmonary circulation. Normally a low resistance, high compliance system. The A, that is decreases in PaO2, causes hypoxic vasoconstriction that shifts the blood away from poorly ventilated regions of lung to well ventilated regions of lung. Perfusion limited gases are oxygen in normal health, carbon dioxide and nitrous oxide N2O. Gas equilibrates early along the length of the capillary. Exchange can be increased only if blood flow increases. Diffusion limited gases, oxygen in emphysema and fibrosis, and carbon monoxide. Gas does not equilibrate by the time blood reaches the end of the capillary. Oxygen diffuses slowly while carbon dioxide diffuses very rapidly across the alveolar membrane. Disease states that lead to diffusion limitation, example pulmonary fibrosis, are more likely to cause early hypoxia than hypercapnia. Chronic hypoxic vasoconstriction may lead to pulmonary hypertension with or without cor-pulmonale. Diffusion, that is J, is equal to A into dk multiplied by P1 minus P divided by delta X, where A is the area, delta X is alveolar wall thickness, dk is diffusion coefficient of gas, P1 minus P2 is equal to difference in partial pressures. A decreases in emphysema, whereas delta X increases in pulmonary fibrosis. DLCO is the extent to which carbon monoxide passes from the air sacs of lungs into the blood. Pulmonary vascular resistance, or PVR, is equal to pressure in pulmonary artery minus pressure in left atrium divided by Q. So where P pulmonary artery is pressure in pulmonary artery, PL atrium is approximately pulmonary artery occlusion pressure, also called the pulmonary capillary wedge pressure. And Q is cardiac output, that is in ml per minute. Next, remember delta P is equal to Q into R. So R is equal to delta P divided by Q. So where R is 8 multiplied by N into L divided by pi R Q, pi R to the power 4, where R is the resistance, N is viscosity of blood or stickiness, L for vessel length, and R is the vessel radius. Next, ventilation perfusion mismatch. Ideally, ventilation is matched to perfusion per minute. That is, VQ ratio is equal to 1 for adequate gas exchange. Lung zones, VQ at apex of lung is equal to 3, that is wasted ventilation. VQ at the base of the lung is 0.6, wasted perfusion. So both ventilation and perfusion are great at the base of the lung than at the apex of the lung. With the exercise, that is increased cardiac output, there is vasodilatation of the apical capillaries. As a result, the VQ ratio approaches 1. Certain organisms that thrive in high oxygen, that is example tuberculosis, flourish in the apex. VQ is equal to 0, that is in airway obstruction. Or shunt. In shunt, 100% oxygen does not improve PaO2. Example, foreign body aspiration. VQ is equal to infinity, that is blood flow obstruction. Physiological dead space. Assuming less than 100% dead space, 100% oxygen improves the PaO2. Example in pulmonary embolus. Zone 1, zone 2, zone 3. Here we are seeing in zone 1 the pressure in the partial pressure in the alveolar air is more than the pressure in the arterial, and PV is pressure in the venous blood. So in zone 2, the pressure in the artery is more than pressure in the alveolus, is more than the pressure in the venous blood. Zone 3, the pressure in the artery is more than the pressure in the venous blood, and finally the least is in the alveolar blood. So alveolar gas equation, that is PaO2 is equal to PiO2 minus PaCO2 divided by RQ. Approximately 150 millimeters of mercury minus PaCO2 divided by 0.8. Here PaO2 is the alveolar PO2, PiO2 is the inspired pressure of oxygen in the inspired air, PaCO2 is the arterial PCO2, RQ is the respiratory quotient, that is equal to carbon dioxide produced divided by oxygen consumed. Next, carbon dioxide transport. Carbon dioxide is transported from tissues to lungs in three forms. One is bicarbonate, next carbaminohemoglobin and dissolved carbon dioxide. So bicarbonate is the maximum, that is 70 to 90%. So the bicarbonate chloride transporter on RBC membrane allows bicarbonate to diffuse out to plasma and chloride to diffuse into the RBC. Chloride shift. So via facilitated diffusion counter transport. Second is carbaminohemoglobin or HbCO2, that is approximately 10 to 20%. Carbon dioxide which is bound to hemoglobin at end terminus of the globin, not heme. Carbon dioxide favors deoxygenated form, that is the oxygen unloaded. Next is dissolved carbon dioxide, that is approximately 10%. In lungs, oxygenation of hemoglobin promotes dissociation of H plus from hemoglobin. This shifts the equilibrium towards carbon dioxide formation. Therefore, carbon dioxide is released from RBC, that is the Haldane effect. Majority of the blood carbon dioxide is carried as bicarbonate in the plasma. This is the equation. So this is the first method. This we are seeing the chloride bicarbonate transporter first. Next is the methyl hemoglobin, then the dissolved carbon dioxide. Next, hypoxia and hypoxemia. Decreased oxygen delivery to the tissues. Commonly it is decreased due to decreased cardiac output, hypoxemia, or insufficient oxygenation of the blood with low partial pressure of oxygen, ischemia, anemia, carbon monoxide or cyanide poisoning. So first hypoxemia, there is a low decreased inspired oxygen tension, that is most commonly due to a low pressure in high altitude. Next, hypoventilation due to an increase in the partial pressure of carbon dioxide seen in CNS depression from opiate overdose, obesity, hypoventilation syndromes, neuromuscular weakness. 3 is diffusion limitation, example fibrosis. 4 is VQ mismatch, normal perfusion where there is edema or decreased perfusion in areas of normal ventilation, example in pulmonary embolism. VQ mismatch when the perfusion is normal but there is edema. And right to left shunt, that is extreme of VQ mismatch. Normal perfusion in areas of no ventilation can be anatomic. Example, intracardiac shunt or physiologic, that is perfusion of non-ventilated alveoli in ARDS. Hypoxemia, there is insufficient oxygenation of blood, so low partial pressure of oxygen. So what we studied was about hypoxia. Next is hypoxemia. Hypoxemia means insufficient oxygenation of blood. Next, hemoglobin. Normal adult hemoglobin Hb is composed of 4 polypeptide subunits, 2 alpha and 2 beta, that each bind one oxygen molecule. Hb is an allosteric protein that exhibits positive cooperativity when binding to oxygen, such that oxygenated hemoglobin has high affinity for oxygen, deoxygenated hemoglobin has low affinity for oxygen, so which promotes release or unloading of oxygen. The protein component of hemoglobin acts as buffer for H plus ions. Myoglobin is composed of a single polypeptide chain associated with one heme moiety, higher affinity for oxygen than hemoglobin. Oxygen content of blood. Oxygen content is equal to oxygen bound to hemoglobin plus oxygen solubilized in plasma, that is equal to 1.34 into Hb into saturation of oxygen plus 0.03 into partial pressure of oxygen. So SaO2 means the percentage saturation of arterial blood with oxygen. 0.03 is the solubility constant of oxygen. PaO2 means partial pressure of oxygen in arterial blood. Normally, 1 gram hemoglobin can bind 1.34 ml of oxygen. Normal hemoglobin amount in blood is 15 gram per dl. Oxygen binding capacity is approximately 20 ml of oxygen per dl of blood. With low hemoglobin, there is a decrease in the oxygen content of arterial blood, but no change in oxygen saturation and PaO2. So, oxygen delivery to the tissues is equal to cardiac output multiplied by oxygen content of blood. So, what happens in carbon monoxide poisoning? The hemoglobin concentration is normal, saturation of oxygen is low because carbon monoxide competes with oxygen, partial pressure of oxygen is normal, total oxygen content is low. Anemia, hemoglobin concentration is low, saturation of oxygen is normal, PaO2 is normal, total oxygen content is low. Polycythemia, there is an increased hemoglobin concentration, saturation of oxygen is normal, partial pressure of oxygen is normal, and increase in the oxygen content. In methemoglobinemia, Hb concentration is normal, saturation of oxygen is low because Fe3 plus is poor at binding oxygen, partial pressure of oxygen is normal, total oxygen content decreases. In cyanide toxicity, hemoglobin concentration is normal, saturation of oxygen is normal, partial pressure of oxygen is normal, total oxygen content is also normal. Next, the oxyhemoglobin dissociation curve. That is the shifts in oxyhemoglobin dissociation curve. ODC, it reflects the local tissue oxygen needs. Can be helpful or harmful. Helpful where it meets the metabolic needs, or harmful in toxicities or pathological situations. The right shift in the ODC. So the right shift, this is the ODC, normal ODC. The right shift in the ODC reflects a decreased hemoglobin affinity for oxygen. Means there is increased oxygen unloading at the tissue. Physiologically, it occurs with oxygen needs like exercise, low pH, increased temperature, fever, hypoxia, when there is an increase in the 2,3-BPG at the cellular level caused by increase in H plus and increased carbon dioxide, which is created by the tissue metabolism or the Bohr effect. Left shift in ODC reflects increased hemoglobin affinity for oxygen. So there is a decreased unloading at the tissue. Physiologically occurs with decreased oxygen needs when the temperature is low, and in pregnancy where the fetal hemoglobin has higher oxygen affinity than adult hemoglobin, and increased oxygen binding due to decreased affinity for 2,3-BPG. So left shift driving oxygen across the placenta to the fetus. Pathologically, it occurs with increased carbon monoxide, increased hemoglobin, and genetic mutations where there is a low 2,3-BPG. So the mnemonic is left means lower. ODC has a sigmoid shape due to positive cooperativity. That is, tetrameric hemoglobin molecule can bind 4 oxygen molecules and has high affinity for each subsequent oxygen molecule. Myoglobin is monomeric and thus does not show positive cooperativity. So the curve lacks the sigmoidal appearance. So this is the myoglobin curve. This is our ODC, which has a sigmoidal curve. Next, coming to response to high altitude. Constant FiO2 but low Pb means decrease in the atmospheric oxygen, and decreased partial pressure of oxygen, increased ventilation, decreased PaCO2, respiratory alkalosis, which causes altitude sickness like headache, nausea, fatigue, lightheadedness, sleep disturbance, and chronic increase in ventilation. Increased erythropoietin increases hematocrit and hemoglobin because of the chronic hypoxia. So there is an increased 2,3-BPG. It binds to hemoglobin. There is a rightward shift of the oxyhemoglobin dissociation curve, and there is an increased oxygen release. Cellular changes, there is an increased mitochondria. Increased renal excretion of bicarbonate to compensate for respiratory alkalosis. It can augment with acetazolamide. Chronic hypoxic pulmonary vasoconstriction. There is an increased pulmonary vascular resistance and pulmonary hypertension. and right ventricular hypertrophy. Response to exercise. There is an increased heart rate and increase in the SV, so which increases the Q. There is an increase in the pulmonary blood flow and increase the VQ ratio from base to apex, which starts becoming more uniform. There is an increased cellular respiration, increased carbon dioxide production, and decreased pH at the tissue, which causes a right shift of the ODC, tissue offloading of more oxygen, and increased oxygen consumption. Increase in the respiratory rate meet increased oxygen demand and removes excess carbon dioxide. There is an increased pulmonary blood flow. PaO2 and PaCO2 are maintained by the homeostatic mechanisms. PvO2 due to increased oxygen consumption falls, and PvCO2 increases due to increased carbon dioxide production. Methemoglobin. Iron in hemoglobin is normally in a reduced state, that is ferrous state. So oxidized form of hemoglobin does not bind oxygen as readily as ferrous, but has an increased affinity for cyanide, that is increased tissue hypoxia from decreased oxygen saturation and decreased oxygen content. So this Fe3 plus form is called methemoglobinemia. While typical concentrations are 1 to 2%, methemoglobinemia will occur at higher levels and may present with cyanosis. It does not improve with supplemental oxygen and with chocolate colored blood. They present with cyanosis and chocolate colored blood. Cyanosis which does not improve with supplemental oxygen. Dapsone, local anesthetics like benzocaine and nitrites, example from dietary intake or polluted water resources, can cause poisoning by oxidizing Fe2 plus to Fe3 plus. Methemoglobinemia can be treated with methylene blue and vitamin C. Next, cyanide versus carbon monoxide poisoning. Both inhibits aerobic metabolism via the inhibition of complex 4 of the ETC, that is the cytochrome C oxidase. Hypoxia does not fully correct with supplemental oxygen and increased anaerobic metabolism. So let us compare cyanide and carbon monoxide. First is the exposure. So cyanide is exposed when there is synthetic product combustion, amygdalin ingestion which is found in the apricot seeds, cyanide ingestion example in suicide attempts and fire victims. And it presents with headache, dyspnea, drowsiness, seizure, coma. Skin may appear flushed or cherry red. Venules in retina appear bright red. Breath may have bitter almond odor. Labs will show normal PaO2. There is an elevated lactate anion gap, metabolic acidosis. Effect on the oxygen hemoglobin curve. The curve is normal. Oxygen saturation may appear normal initially. Despite ample oxygen supply, it cannot be used due to ineffective oxidative phosphorylation. Treatment is by decontamination. Remove the clothing. Hydroxycobalamin which binds cyanide, produces cyanocobalamin, and then renal excretion. Nitrites which oxidize hemoglobin to methemoglobin, bind cyanide, and cyanomethemoglobinemia can decrease the toxicity. Third one is sodium thiosulfate. It increases the cyanide conversion to thiocyanate, which causes the renal excretion. Next is carbon monoxide. So what happens in carbon monoxide poisoning? Exposure could be through motor exhaust, gas heaters, and fire victims. Presentation: headache, vomiting, confusion, visual disturbances, coma. They may have cherry red skin with bullous skin lesions. Multiple victims may be involved, like family due to faulty furnace. Labs will show a normal PaO2, elevated carboxyhemoglobin on co-oximetry, classically associated with bilateral globus pallidus lesions on MRI, although can rarely be seen with cyanide toxicity. And there is a left shift in the ODC, increased affinity for oxygen but decreased oxygen unloading in the tissues. Binds competitively to hemoglobin with more than 200 times greater affinity than oxygen to form carboxyhemoglobin. So that's how it decreases the oxygen saturation of hemoglobin. And treatment is 100% oxygen and hyperbaric oxygen if severe. So that is the end of respiratory physiology.